healthcare, patients, and a patient-centric experience. So, Christina, welcome, and delighted to have you with us, and I'll leave the floor to you.
Okay, welcome everyone. The good doctor treats the disease, but the great physician treats the patient who has the disease. Good afternoon. My name is Christiana Eggy. I'm a registered nurse, and I've been a dementia care advocate for the past 26 years. And today, I'll be talking to you about patient-centered care, the challenges and sustainable solutions. However, I feel that the best way to explain patient-centered care is to show you what patient-centered care is not. And the story of this lady that you'll be seeing is a lady that has lived with us for the past 20 years. She developed pneumonia and she was admitted to the hospital. The team decided that she needed further treatment at a rehabilitation center. And so this will be one of my first visits to her, the clips. The first clip is my first visit to her at the hospital, and the next two clips are visits at the rehabilitation center. I want you to imagine that this woman is your mom, your grandmother, or your aunt, and to look at this story through those lenses and see how it makes you feel. We say hi, everyone.
Hi, everybody.
Yes.
I miss you so much.
Oh.
And I love you so much, all of you.
Oh, that is sweet.
Yeah.
So you're doing good? How was dinner?
And then open that.
You haven't opened it yet?
Open it.
I should open it?
I don't like what you're doing.
Oh, you don't like what is in there? So you know, everyone misses you, Eileen. They miss you badly. They're like, when is she coming? Oh my gosh, so you don't. But the mashed potato looks good though. So you don't want minced food?
No.
I don't know why they're not giving you regular food. I will talk to them again, okay? But you don't eat. I do? Thank you. So are you eating better here? Are you eating now? What kind of food are they giving you?
Puree.
Again? You still on puree and you're not eating. You lost so much weight.
Yeah, I took really the weight.
So, Mama, did you eat today? Did you eat?
I gave me diarrhea.
What's giving you diarrhea?
What they gave me to eat.
What they give you to eat is giving you diarrhea? You lost so much weight, Mama. Oh, I feel so bad. Oh. You should come home soon, okay? When they ask you to walk, anytime they ask you to do exercise, you should do, okay?
I exercise.
Yeah, so you can come home soon.
To die?
To do what?
To
No, we don't want you to die. We miss you. We want you to come back. Come back soon. But you have to walk. That definitely is not person-centered care. She returned home to us, still not working, hair matted, with several pressure sores, like I've never seen in about 40 years of nursing. That was epic failure of the healthcare system. So what can we do about the challenges facing person-centered care? I'm going to address three main areas. Empathy in the digital age, balancing individualism with standardization, and the challenges of patient and family advisory council. So, with increase in technology, we are relying more on telemedicine, electronic records, and AI-driven healthcare. And the patients are starting to feel that disconnection and dissatisfaction. So empathy is not an option. Empathy is the very core of patient-centered care. Without empathy, there's dissatisfaction, there's lack of communication, and there's less adherence to care. So what can we do about this? We can train healthcare practitioners on digital bedside manners. What does this mean? We can help healthcare practitioners to learn how to incorporate empathy into their care by practicing active listening, making eye contact, personalizing the interactions with patients, calling them by name, leaving ample time for complex cases, and then following up with a call. Automation is very important, but we should use it for efficiency and use human judgment in making critical decisions. The other problem is how to balance individualism with standardization. Standards procedures are amazing. They ensure safety, they ensure efficiency, and also compliance with regulations. But what they do, if standards are too rigid, is they limit the flexibility of practitioners being able to use, their own judgment to give that personalized care to different patients. Another thing that impacts this is the high turnover of staff and staffing shortages. This leads to, staff being overwhelmed or even burned out, and they become task-oriented, not, being able to pay individualized attention, learning about the residents and, treating them with empathy and compassion. What can we do about this? We can, create, flexible standards and empower staff to be able to make judgments. Everyone is unique. No two people are the same. So we need to take each person and, treat them according to their needs, their preferences, as well as their cultural sensitivity. So we also need to, be able to use data, helping, using patient history, using collaborative history and analytics to create personalized care. We did advocate on behalf of that patient, but no one was listening. So my second case study is about a gentleman who lived with us, again, for the past 20 years. He fractured his hip last fall, and after he had surgery, he did not qualify for rehabilitation because dementia is a label that says you cannot do anything. It's a label that sort of writes you off. So on the other hand, this particular gentleman is very high functioning. He's a retired teacher. He can still do mathematical equations and discuss scientific things with you, but they did not take the time to know him or to actually build the care around him. So in spite of our advocacy, they did not yield. They said it was against hospital policy. So one of the staff who has worked with him for the past 20 years decided to take matters into her own hands. She'll come to work in the morning, finish her chores, I will have her replaced, and she'll take the bus to the hospital to assist the physiotherapy and the team there to help rehabilitate him. They would not cooperate with us. So fortunately for him, a bed became available on the main floor, and he came back home to us. In the first week, he was up and walking with assistance. And by the second week, he was walking independently with a walker and has continued to do so to this day. Imagine that gentleman ended up maybe in a nursing home, was not given the opportunity to walk. He will become very miserable because he can be that at times. And then the medications will go up and the quality of his life will go down. So patient-centered care is very, very important in maintaining respect, dignity, and quality of life. My third challenge is maintaining patient and family advisory council on a budget. What institution doesn't have financial constraints? But the patient and family advisory council is very, very important. They are the watchdogs for the patients. They are able to influence healthcare. They can, have influence on policies, on care plans, and day-to-day living. As well, they help to maintain transparency and inclusion. So, how can an institution maintain a robust patient and family advisory council? Like limited participation can be ward off by having virtual engagement that will encourage more participants, and using local businesses, collaborating with them and asking for support, as well as using volunteer appreciation and using online surveys to cut costs, and small focus groups in addition to the larger groups will be helpful to maintain this vital aspect of healthcare. My third case study is my personal history. My now 28-year-old son, when he was just 14, he was having the summer of his life. He was the first 14-year-old to be named to the Canadian basketball junior men team. And he had just returned from an overseas trip training with Team Canada. That year, they were also playing the national basketball tournament in Toronto. He was the captain of Team Ontario. This was happening at the Humber River Humber College. As the tournament went on, I could see that he was not breathing well. After running up and down the court, I would see him with his hands on his knees, catching his breath. After that tournament, where he was named the MVP, he had played on a collapsed lung and was named the MVP. I took him straight to the University of Toronto Athletic Center, where the doctor diagnosed him with pneumothorax. But she said to us, this can be easily treated at the local hospital. You do not need to go to the hospital for sick kids. So off we went, and they inserted a chest tube. It was a very painful procedure. We went home. A couple of days later, his lung had re-expanded, so they took out the tube. 2 weeks on our way out to the follow-up appointment, I was already in the car, and he called out, "Mom, the pain has returned." So instead, we drove off to the emergency room. While at the emergency, they found out that not only had the lung collapsed, but it had collapsed even in a greater area. So they inserted another tube. It was, again, really painful. He could not sleep, so he slept on a recliner with his older brother perched on the couch beside him. After several visits to the hospital, we were referred to see a thoracic surgeon who gave us a prognosis of gloom and doom. He basically told us that my son will never play basketball again. I told him that we're preparing to travel to the US with my older son who was starting university. And he said that if my son flew, his lungs will explode mid-air. So with that hopelessness, we drove back home. And after a family conference, we decided the next day to seek second opinion. And on my way to bed that night, he called out, "Sick kids." And I thought, God put it in your heart. So we went to see kids the next day. From the moment we stepped into the emergency room, hope returned. The doctors and the nurses were full of smiles. And they kept saying, "Oh, you have a pneumo? Don't worry, we'll have you all fixed up in no time." The surgeon came and he told my son that he had actually played basketball in his undergrad years at U of T. And he said, "I'll have you back on the court in a month's time playing." And what a difference. And I asked, "Can he ever fly again?" He said, "Of course. Within the month, he should be able to fly." So my son had surgery, and we went back for the follow-up after about a month. And the surgeon actually was outside when we got there. He came in, stood very playfully by the doorpost and say, "What are you doing in my office? Get out, go play ball. And if you make it to the pro, save me courtside seats." What a difference. And my son went on to play college basketball, and he just finished in his postgraduate studies. They just finished their tournament, and his team won. What a difference. So, can patient-centered care be practiced? Yes. Most areas, especially in children's sections, this is being practiced. And you know what my children said? "Mom, when we make it, we're going to be donating to the hospital for sick kids." So we're talking about not being able to maintain patient and family advisory council on a tight budget. Those same patients we treat, if we're good to them, they are the donors of the future. Oh, sorry. Okay. So, patient-centered care is actually supported overwhelmingly by Canadians. From the Canadian statistics, the numbers range from high 70s to high 80s. People want to have a voice in their healthcare. People want to, be treated with respect and dignity. People want collaborative care and everything that goes along with patient-centered care. So, what can we do to enhance this quality of care? I would say, I will start by saying we need to employ the 6 R's. It starts at the top. So the right leadership, a leadership that embodies respect, dignity, empathy, and compassion. It trickles down. Empowering their staff to be able to use their own judgment in situations and respecting those actions. The right knowledge, not just knowledge, book knowledge, relational knowledge, where you learn to be a human and you have bedside manners. Because without empathy, you do not have bedside manners, and patient-centered care would not work. Having the right skills, training staff on empathy, compassion, respect, dignity, culture, using trainings like gentle persuasion, dementia ability, the right tools, of course, bring in the technology, use patient data like history, not just from patients, from families, and from collaborative healthcare practitioners, as well as the right attitude. Attitude goes both ways. Attitude within the work environment and attitudes for patients. All of us will be patients one day. What I tell people these days when they're in the hospital and they're complaining, I tell them that is why they call you patient. You have to have patience. We all will experience this, either personally or family members. How do you want to be treated in your most vulnerable time? Also, also, we need to, listen to the voices of people that we serve. We need to let them have an input in their own care. We need to measure care, and we need to employ empathy, compassion, respect, and dignity in all aspects of care. Let us weave it into the very fabric of the healthcare system. Listening to the voices of people that we care for. Let's leave that culture of label behind. Saying schizophrenia on bed 4, dementia on bed 5, SOB on bed 6. Sorry, I did not just swear. Shortness of breath. Let's take that label off. Let's start calling people by their names. Beyonce said it well. Say my name, say my name. Mr. Smith, Mrs. Doe. And I want to leave you with the words of Maya Angelou. I've learned that people will forget what you said. People will forget what you did, but people will never forget how you made them feel. I invite all of you to join me as we treat every patient with respect, empathy, dignity, and compassion, because it is how we make them feel that will have a lasting impact. Thank you.
Thank you very much.
You're welcome.
So we've got a little bit of time if there's reflections that people have or questions.
Thank you.
Now you can hear me. So I'm assuming that patient outcomes are better with a patient-centered approach, yes?
Yes.
So my question is, why is there a reluctance with hospital and healthcare leadership to adopt these practices if it does improve patient outcomes?
As I said before, with turnovers and shortages of staff, training does not get carried over. We need to build a cohesive healthcare system. We need to have a healthcare system that rests of inclusion, respect, and consideration. How can you pour out of an empty cup? If you, as an employee, does not feel respected or empowered, you are overworked. How can you give? So it comes from the top. We need to build, when a lot of healthcare systems are very toxic, and since the pandemic, a lot of healthcare practitioners have left the practice because they just feel overwhelmed and burnt out. But we could make this more user-friendly, by empowering, by proper training, by, support, recognition, and incentives. It doesn't take much, but you can get so much out of it.
May I add more nurses and senior leadership? People who've been at the bedside.
Yes, that's another thing. A lot of the time, they bring people that don't know healthcare. They bring in managers just to make the budget balance, and they have no clue of what nurses do. It doesn't work. You have to know and feel what I feel to be able to understand the work that I work.
Let me just share a couple of perspectives, if I can, around that, because there is a saying that culture arrives by foot, but it leaves by express train. And I think that, whilst a patient-centered approach may well be obvious to all of us, it's building and generating that deep care, that culture, that sustains individuals, it sustains changes in leadership, it sustains budgets, it sustains, it's at the heart. And that's hard yards to actually get after around it. But, it's something that whether you work in patient experience or customer experience, that cultural piece is really at the heart of what we see significant change occurring around it. Sorry, there was a question here.
Well, first of all, I just want to say thank you for the incredible work that you do and taking this approach to patient care. It's amazing. I come from paramedic services, and what I notice a lot of times is working with the hospitals, we're seeing incivility between the different services or, LTCs versus hospitals. And how are you navigating that? Because as much as we can do so much around patient care, a lot of times our patients do end up in the hospitals, and it's that advocacy piece. It's how are you navigating that?
It's tough. I think we need to build a culture of trust. We are all serving the same people, whether you are in the hospital, whether like paramed agency or LTC and so forth. See, the one thing about Canadian culture is that if you choose to live in a retirement home, you become an enemy of the state. You don't get anything. It's all about long-term care. But very good care is being done in retirement home settings. And that element of trust is lost. Not just even the healthcare system, even with policing. My background is in mental health. When I started Alexis Lodge, I took in everyone because there's this stigma around mental health, dementia, and ageism. So what I do is I try to care for everyone because I worked on the crisis unit at CAMH for 10 years, so I know how to manage any form of psychotic behavior. And so I would take people in. When they become violent, the police will not even take them to the hospital. They'll tell me, oh, you admitted them, you take care of them. I'm a nurse. I don't write prescriptions. And if I'm telling you that the other people in my home are in danger and I need help, why won't you help me? Fast forward, they take them to the hospital. Then the hospital is calling me right away to come and sign an undertaking that I'll take that patient back. I don't own people. We bring back our patients, bring them, it's their family, they come back home. Just admit them, reassess them, give them the treatment they need. So that is me being someone from a facility. Now let's talk about families that live in the community. You're taking care of your loved one with dementia. Now they are experiencing about 40% of patients with residents, with individuals living with dementia would exhibit behavioral problems. The hospital will not admit them, and nursing homes will not touch them with a 10-foot pole. So what are the families supposed to do? They become burnt out, they become ill, and the elderly ones, according to research, may die before the people they are caring for. Or those two elderly couple that are looking after each other, one of them falls, breaks their hip, and now they become a burden on the system. So if only, people that make these laws or people that make this budget, if only they would take critical view of what's going on and create little supports in the system, it will save a lot of money in the long term. Why don't we, take the individual, let that individual live in the place that is most suited for their needs, rather than pushing nursing homes? There are up to 7-year wait in some homes. What are these people supposed to do? What are families? Dementia is a 24/7 care. What are families supposed to do? They don't even pay you to care for your loved ones. So one of the greatest cause of burnout is finances. So there's so much to be desired because dementia is growing at an alarming rate. Last year, I will tell you it was 600,000+. As of January, the Alzheimer's Society of Canada said dementia, more than 700,000 people have dementia. And by 2030, over 1 million Canadians will have dementia. So if we have problems now, what's going to happen then?
Any final questions? Well,
Thank you.
Christiana, thank you very much for what was a very moving and very personal set of stories. Yeah?
Thank you.
Your encouragement to all of us to lean into patient-centered care. Thank you.
Yes, thanks for the opportunity.